Good day, everyone, and welcome to the Reproductive Health and Fertility Options Before and After a Cancer Diagnosis Conference hosted by nbmtLINK. Today's call is being recorded. At this time, I'd like to turn the call over to Jennifer Gillette. Please go ahead.
Thank you, April. Yes, I am Jennifer Gillette, the staff social worker at the National Bone Marrow Transplant LINK, and I'd like to welcome everyone on the call with us today. Today's program will focus on reproductive health and fertility options before and after a cancer diagnosis. A special thank you to the Leukemia and Lymphoma Society and our LINK partners for making this program possible today. Just a basic outline so everyone knows how our program will run today. We're going to have a couple of minutes of introductions about nbmtLINK, and then we will have professional speaker fertility preservation specialist Kristin Smith. And then we will have a survivor, Megan Connolly, speak. And then we will open up half of the call for questions. Then at the end, we'll wrap up with a few resources and thank you. For those who may not be familiar with the LINK, our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate their transplant journey are webinars, podcasts, blogs, lunch and learn calls like the one you are on today, and we serve several topics such as chronic graft versus host disease, disease-specific information, caregiving, coping, treatment options, and survivorship after a transplant. We also have a wonderful peer support mentor program for patients, caregivers, and donors, our second birthdays recognition program, and we have books and referrals and support from a licensed social worker. Please feel free to reach out to us if you're interested in any of our services. Before we begin today's program, I'd like to review a few housekeeping items to maximize the experience for all on the call. First of all, please be mindful in being concise with your questions so that we may answer as many as possible today. Also, please know that the information provided in this program is meant to stimulate conversation with your own healthcare provider and is not meant to replace your individualized medical plan. So now on to the educational part of our program. We are so excited and honored to introduce you to our first speaker today, Kristin Smith. Kristin is the program manager for fertility preservation. She consults with all young, newly diagnosed oncology patients at Northwestern's Lurie Cancer Center to help each patient understand their individual fertility risks associated with treatment as well as options for fertility preservation. She works extensively with young adult oncology survivors to help each patient explore their unique family-building options and reproductive health post-treatment. Kristin helps run the National Physicians Cooperative of the Oncofertility Consortium by providing support across the country to providers who participate in national fertility preservation studies, and also answers the National Fertility Hotline to triage patients for fertility preservation across the country. We are so grateful to have you here with us today, Kristin. Thank you.
Yeah, thank you so much for asking us and for highlighting this really important topic. For me, this is my whole entire world is taking care of adolescent and young adult oncology patients during an existential crisis like a cancer diagnosis. And I've been in this role here at Northwestern for 10 years next month, and just feel very honored and privileged that I get to be a part of this journey for so many people. And so just to give you kind of a quick overview, we're so fortunate here at Northwestern to be home to the Oncofertility Consortium, which really started with a basic science researcher here at Northwestern named Dr. Teresa Woodruff, who realized that we as healthcare providers didn't necessarily do a great job of offering and discussing fertility preservation at the time of diagnosis. And so she applied to the NIH for one of their very prestigious roadmap grants and was awarded that so that she could found the Oncofertility Consortium, which in turn now runs the National Physicians Cooperative and also a global cooperative, so that we can really be at the forefront of ensuring that basic science is getting to the bedside of patients as quickly and seamlessly as possible. And when I was initially hired 10 years ago, I was hired as the patient navigator. So essentially a person to see patients through and around barriers that are associated with fertility care in the midst of a diagnosis like cancer. And, just to give you kind of a brief overview, I'm going to chat about sort of general male fertility. We'll talk through some of those fertility preservation options that we offer up front, and then also talk about, as a male patient, where do you go from here? And then we'll also highlight the female fertility side of things, what options exist for fertility preservation. And then again, also talk about, as a survivor, where do I go from here? I'll provide some additional resources, and then, kind of be certainly available for questions. And you'll have my phone number as well if you want to call for sort of individual discussion and any follow-up and things like that. So when we think about male fertility and the impact that cancer treatment has on male fertility, what we really are concerned about are the spermatogonia cells. And so these are the cells in the testicles that make sperm for men. And what we know is that chemotherapy can damage those cells. Radiation therapy, obviously, to the testicles as well can damage those cells. And then certainly surgical removal of the testicles damages and removes those cells. So when we have a young man who's getting ready to get chemotherapy or radiation therapy to the testicles or surgical removal, it's certainly important that we talk about trying to bank some sperm prior to any of that treatment starting. And sperm banking is fairly straightforward. Basically, typically there's a urology consult that happens with some baseline hormone testing, some infectious disease testing that's strictly for storage purposes. And then a sample is produced typically via masturbation. It's analyzed in a lab, and that individual finds out more about his sperm than he probably ever wanted or needed to know. So things like sperm counts, which is the number of sperm that are present, that's typically in the millions per milliliter. The motility, which is how the sperm are moving, and then the morphology, which is how the sperm are shaped. From that one sample, the sperm is then frozen into as many vials as possible. And that number of vials that can be saved is totally dependent on the individual ejaculate volume as well as the sperm counts. So in some cases, I have patients that come through and give one sample of sperm, and we bank 10 vials from that one sample. But in other cases, especially when someone's very sick and they're giving a sample, sperm production has been pushed a little bit lower on the totem pole of things to do for the body. So in those cases, maybe sperm counts are lower than we'd expect, and we get a lower number of vials. We try to freeze as much as we can, given the time restraints that we often have in these situations. If someone can't produce a sample via masturbation, then certainly we'll have urology consult them about doing something called a TESE, which is a testicular sperm extraction. That's a surgical procedure where we can go directly into the testicle and retrieve sperm. When we do that, we're typically getting very low numbers of sperm, but at least it's something that we can then freeze as well. And then for our pediatric patients, 10 years ago, there wasn't really an option for someone who wasn't already making sperm, so someone who hadn't already gone through puberty, to preserve their fertility. But researchers now across the country, and specifically a researcher at Pittsburgh named Kyle Orwig, has started a testicular tissue cryopreservation protocol. And this is pretty amazing. So we can actually do a wedge resection of a young boy's testicle and save that tissue with the hope that we can utilize that tissue in the future and actually repopulate his testicles with his own spermatogonia stem cells so that he can make sperm on his own in the future. That's typically only offered under experimental protocols at very select institutions around the country, but we're seeing it gain tremendous popularity, and we're so thrilled to be able to offer something to our prepubertal men and boys here. And so, as a young adult survivor, I often get the question of, I have no idea what my fertility is. What do I do now? For men, it's, again, fairly straightforward in that a semen analysis will typically give us most of the information that we need. So if you can be seen by a local, typically a reproductive urologist, they can refer you for a semen analysis test. And from that semen analysis, you'll have a really good idea of exactly how much of an impact treatment had on your individual fertility. And then based on those results, a reproductive urologist can make recommendations and kind of chat through what next steps look like. If it's a situation where, unfortunately, the treatment rendered someone completely sterile or called azospermic, that means no sperm is found in the ejaculate, there may be a role for attempting a TESE at that point, that testicular sperm extraction, to see if there's anything in the testicle. And still, if we get to a point where none of that has worked and we're still not finding sperm, then absolutely we talk about alternative family building. use of donor sperm, which is done probably way more often than you'd ever realize in the United States, through a multitude of different sperm banks that are available. We'll certainly talk about adoption as a great way to family build as well. But a reproductive urologist is really going to be one of the best bets to go to as a survivor to kind of figure out what's next for me. And now onto the female side of things. So not surprisingly, female fertility is much more complex. So as women, we're born with all the eggs we're ever going to have with no way to make new eggs. And as we get older as women, we just constantly lose those eggs. So for most women in the United States, we're done family building really in our early 40s. And that's because that cohort of eggs that we have has gone down and dwindled so much that we have very few numbers of eggs left. And the eggs that are still left aren't typically genetically competent. So that's why you also see as we get older as females, birth defect rates will increase as we get older. And that's simply because the DNA inside of the egg has been sitting in that egg much longer. And so sometimes doesn't perform as well as it should in terms of kicking out an extra copy of a chromosome or replicating the way that it would normally do. And so when I meet with female patients, we talk about lots of options, right, for fertility preservation. The most commonly utilized options are egg and embryo freezing. So this is a process where for about 2 weeks, a female takes injections that tell the ovaries to grow lots of eggs at once. In a regular menstrual cycle, you typically grow one egg at a time. You ovulate out that one egg, and if it's not met with sperm, then you have a period about 10 to 14 days later. In this process, when we're trying to get as many eggs as possible, we are having you give yourself these small injections that are basically the same signal that your brain would send your ovaries anyway, just now at a higher dose. So instead of growing one egg at a time, you're hopefully growing 5, 10, 15, 20, 25 eggs at a time, as much as your body would give us. And during that 2-week time frame, you're seen pretty frequently in the reproductive endocrinology office for monitoring visits to make sure that the follicles are growing, the follicles are what hold the eggs, and that we should see estrogen levels rising appropriately. Eventually, again, after about 10, 12 days on these medicines, you're triggered for what's called an egg retrieval. And that's a quick outpatient procedure typically done under conscious sedation, where we go in while someone's asleep and doesn't feel anything or remember anything, and we retrieve eggs directly from the ovaries. Once those eggs are out of the body, they can either be frozen, unfertilized, or if there's a sperm charming is what I call them, if there's a specific sperm source that someone would like to use, we can fertilize those eggs, make an embryo, and then we can freeze an embryo. And once an egg has been fertilized and an embryo has been created, there's more that can be done with that. So we can actually grow that embryo out to what's called the blastocyst stage, and then we can actually even biopsy out cells from that blastocyst and send it for genetic testing. And when we do that, we get a really good idea of whether or not that embryo has the correct number of chromosomes. So is it 46XX or 46XY? And if someone has a known genetic mutation, so if someone's a carrier of something and we know that specific gene, we can actually test the embryos at that stage too, so that someone understands exactly what they have banked and whether or not that embryo is impacted by that same mutation or not. Another option for fertility preservation that was previously experimental, but was just lifted from the experimental label December of 2019, is ovarian tissue freezing. So much like for the prepubertal boys, we'll freeze testicular tissue, oftentimes in prepubertal females where we can't get eggs directly from the ovaries quite yet because they don't mature quite yet, we can actually remove an ovary, isolate the outside of the ovary, it's called the cortex, slice that into strips, and we can freeze those cortical strips. Those strips are frozen until someone would want to come back to use them. And to date, the way that these strips have been utilized to create a live birth has been in thawing the strips, sewing them back together in what looks like a quilt, and then actually transplanting that tissue back into the remaining ovary. The ovarian tissue recognizes its own tissue and starts to grow and mature follicles, just like it normally would have. And this has resulted in over 130 live births worldwide, which is really exciting. The big caveat, though, is that we're taking out this ovary prior to someone seeing any type of cancer treatment. So for any blood diseases, so leukemias, lymphomas, if we're to take this tissue out before the patient's seeing treatment and then actually put it back into someone, there's a chance that we could be reseeding someone with their cancer, which is obviously contraindicated. So in those cases, what we're working on, and specifically what Dr. Woodruff has been working on through the Oncofertility Consortium, has been to isolate the follicles. Again, remember the follicles are what hold the eggs in the laboratory and actually encapsulate them into a three-dimensional alginate system that we've created to coax that follicle and the egg to grow outside the body. So it's something called in vitro follicle maturation. And we don't have it figured out quite yet. So we've done it with human tissue because we actually work together through the National Physicians Cooperative to work on human research tissue. We've been able to grow mature eggs from that tissue, but right now it's horribly inefficient. So while we can do it, it's not quite ready yet for human use. My hope is that, when these young girls who are having their ovaries removed across the street from us at our children's hospital at the age of, 5 or 10, when they come back to see us when they're 25 or 30 or 35 or 40, we figured out this technology and we're able to utilize their ovarian tissue. So talked about egg and embryo freezing, ovarian tissue freezing. Some clinics will offer to put patients on a medication called Lupron prior to starting treatment. Lupron is a medicine that shuts down your ovaries, and so the theory here is that if your ovaries are nice and quiet while you're actively getting chemotherapy, maybe the chemotherapy won't do as much damage to those cells because it's so quiet. And I say maybe in theory because it's still kind of questionable how well it works. So there have been multiple studies published. Lupron's been around for, probably 25 or 30 years as an available medication. And from the studies that have been published, there doesn't seem to be a super clear benefit in terms of ovarian reserve protection from this medication. What we know it does really well is take away periods during treatment. So it's nice to not have to get your period often during treatment, especially for leukemia patients who we're super concerned about blood counts with. So to take away their periods, that's definitely helpful during treatment. Where this has been shown to be effective has been in helping women get their periods back after treatment. When we've looked at pregnancy rates, we don't see any increase in pregnancy rates in patients who get Lupron versus patients who don't. So when we talk about it as an option, but not necessarily an option that for sure is going to work, has some benefits, but also the Lupron medication has some side effects that, you need to be ready for it. Essentially, by shutting down the ovaries, we'll put a patient into a medical menopause. So things like hot flashes, night sweats, insomnia, vaginal dryness, those are all side effects typically of the Lupron medicine that you should definitely talk with your doctor about. And then, as a survivor, kind of where do you go from here? If you have a gynecologist, I think that's a great place to start. So your gynecologist can typically sometimes run ovarian reserve testing. There are a few hormones that can be drawn to kind of determine how many eggs are left in the ovaries, how your brain and your ovaries are communicating with one another, and then can also make a referral if necessary to a reproductive endocrinologist and infertility specialist. So these are OBGYNs who really specialize in the field of fertility, and they can do additional testing to figure out exactly what's going on at this particular time point. Sometimes in survivorship, what we can do if someone's not ready to start family building and there is some ovarian reserve left, we can actually try to save some eggs after treatment. We don't think that treatments had a long-term impact on the quality of the eggs, so we're very comfortable trying to save some of those eggs even after treatment if there are still eggs left. At that point, too, if there aren't eggs left and nothing was frozen, then we can certainly, again, talk about alternative family building options like adoption, an egg donor, an embryo donor, multiple ways to build a family, essentially. But there's another piece to this, too, with reproductive health, and that the ovaries, well, yes, they hold all these eggs. They also make hormones for us that keep us premenopausal. So they make things like estrogen and progesterone that are important to young women and really even as we get into our 30s and 40s. So if the ovaries have been damaged so severely by treatment that there are no eggs left, and then in turn there's no hormonal production, it's really important for you to be seen by a reproductive endocrinologist or someone who can then talk about doing some hormone replacement. And there are tons of resources that are available, both pre and post-treatment. The Livestrong organization has some really great partnerships across the country with different fertility clinics to offer discounted services to help apply for free medications. Another organization is called Team Maggie for a Cure. They offer some cash grants for patients, both pre and I believe post-treatment. And then the Alliance for Fertility Preservation is another fabulous organization. What they've been doing lately has been going around the country and working with different states to help individual states pass bills that require insurers to cover fertility preservation costs in a medical setting like this. And we're so thrilled that here in Illinois we were able to get this bill passed, and you're going to hear from the person who is directly responsible for getting that bill passed. She shared her story with our lawmakers and really influenced the way that they saw this particular bill, and she single-handedly was able to, describe why this is such an important thing for so many young adults around the country.
Wow. Thank you, Kristin, so much. And yes, we are excited to hear from Megan. Megan Connolly is a 2-time cancer survivor of Hodgkin's lymphoma. She was diagnosed at 19 years old and relapsed at 21. Megan had to undergo chemotherapy, total body radiation, and a stem cell transplant. A result of her aggressive treatment, Megan learned that she was at an increased risk of infertility due to the toxicity of her treatment. As a young woman, she always knew she wanted to be a mother, but had no idea that the treatment she needed to save her life could also take away the opportunity to have a biological child. Megan was fortunate enough to be referred to Kristin Smith at the Fertility team at Northwestern Medicine and was able to harvest her eggs prior to treatment. 1 year after her transplant, Megan received a diagnosis of premature ovarian failure at the young age of 22. It was in that heartbreaking moment that Megan knew how fortunate she was to have been able to preserve her eggs, which inspired her to help others in this similar situation. She testified in the Illinois House and Senate to help pass Illinois HB 2617, which mandates insurance companies to cover fertility preservation for patients who are at an increased risk of infertility due to medical condition or treatment. Megan is also active in the young adult cancer community with organizations like Emmerman's Angels. Thank you so much for joining us today, Megan.
Thank you, and thank you for having me. I'm really appreciative that I get the opportunity to share my story, connect with other survivors and caretakers, and just really be a support for patients like myself out there. And just to kind of give a little bit more background, I was originally diagnosed at 19 years old, and when you're a young adult, being diagnosed with cancer is obviously life-changing and absolutely devastating, but there's so many side effects and other things that go into a diagnosis than one would think. One of the main things was the risk of losing my fertility. So being 19 years old, I had absolutely no idea that chemotherapy and other treatments could put me at risk of going into premature ovarian failure. There's so many young adults out there who are not given this information, and education is really power in this case. I'm a perfect example of that. When I was told that I was going to have a stem cell transplant, I was referred to Kristin Smith in the Fertility program here at Northwestern, where they educated me about the opportunities out there, but not only the opportunities, the cost and the time that it would take to go through fertility preservation. In the end, I did choose to harvest my eggs, but there was a lot of resources and support by Kristin and her team that went into making this possible for me. One of the things that comes to mind is I was connected with Livestrong, which helped pay for the very expensive fertility medication that I had to give myself every night. It was thousands of dollars for the medication to stimulate my ovaries so I could produce enough eggs to freeze. So again, that's just another nuisance of the situation that so many patients are either not financially able to pay for that on their own, or they don't have the time to pursue prior to starting their treatment. And after going through the 2 weeks of injections, I successfully was able to have 7 eggs frozen. So I hope to use those sometime in my future. As we mentioned in my bio, 1 year after my stem cell transplant, I was told that I was in premature ovarian failure, and that was determined by a blood test. And again, Kristin Smith referred me to a reproductive endocrinologist who could help determine my fertility. And after getting the diagnosis that I was in premature ovarian failure, on top of, overcoming cancer, it is a hard pill to swallow. And as a young adult, it just made me feel like cancer took away another thing from me. I lost my hair. I had to stop school. But the fact that it took away my fertility was extremely heartbreaking. With that being said, I couldn't dwell on that too long because I was fortunate enough to harvest my eggs. So I still have hope for my future. And like Kristin mentioned, there are also other opportunities to build a family, whether that be through adoption or egg donation, many other options out there. But this is such an important issue for young adults like myself. And as a community, we can share our knowledge and support to hopefully better this experience for the next cancer patient and future survivors.
Well, thank you so much. I appreciate you joining us today. And now we are going to open up the call to questions. So, April, if you could let everyone know how to do that, please.
Sure. If you'd like to ask a question, simply press the star key followed by the digit 1 on your telephone keypad. Also, if you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. Once again, press star 1 at this time. We'll pause for a moment. And a voice prompt on your phone line will indicate when your line is open to ask a question. Caller, please go ahead.
Hi, good afternoon. First and foremost, I need to say thank you to Megan for sharing her story. I appreciate it. And my question is, how do you think my treatment might affect my fertility? I had non-Hodgkin lymphoma in my left shoulder in the bone, and I received 6 cycles of chemotherapy and radiation therapy in the shoulder area. Do you think that have any strong possibility of affecting my fertility?
Hi, so this is Kristin jumping in. I'm assuming female?
Yes.
Yes, perfect. So, when we think about female reproduction, shouldn't be any concern at all about the radiation directly to the shoulder, right? The only time we get concerned about radiation is if it's happening to the pelvic region. So I wouldn't be concerned about that at all. Certainly, though, with the chemotherapy, we know that chemotherapy damages the eggs that are left in the ovaries. So that's why women can go through premature ovarian failure insufficiency after chemotherapy, because it's essentially wiped out all the eggs that are there. And so not all chemotherapies are considered equal. So, like in Megan's case, when she was first diagnosed, she was treated with ABVD, right? And so ABVD does not contain any alkylating agents within that regimen. And we know that alkylating agents are the ones that are particularly most harmful to both female and male fertility. And so I think it would completely depend on, the exact regimen that you had. Oftentimes with non-Hodgkin's lymphoma, there are alkylators like a cyclophosphamide involved in the treatment plan. But it doesn't necessarily mean that just by getting it, it wipes out your fertility entirely. So I think a good way to think about what chemotherapy does to female fertility is that it oftentimes prematurely ages your ovary. So instead of, if you had treatment at 30, instead of having, 31-year-old ovaries when you're done with treatment, based on how much of that alkylating agent you had, you may have the ovaries of, like a 38 or 39-year-old. So it doesn't necessarily guarantee infertility after treatment. Just means that the time you'd have to get pregnant with your own eggs might be shortened. But certainly the best way to get that tested is to see either your gynecologist or a reproductive endocrinologist, and they can do very specific hormone testing and ultrasounds to actually look and see exactly what's going on for you. That will hands down give you the best picture.
Okay. Thank you very much.
Of course.
Next caller, please go ahead. Hearing no response, next caller.
My name is Nicole, and I had a stem cell transplant, and also I did chemo a year before, and I didn't know, I'm in my 30s, and I didn't know, like, is there any, like, financial aid for, like, a surrogate, or how does that work with the surrogate?
Yeah, so using what we call a gestational carrier, someone else to physically carry a pregnancy for you, can be tremendously expensive. Well, technically, it's not difficult to do. As you can imagine, there are significant legal fees that are involved with that, as well as issues with medical insurance, right? So typically, if you're utilizing a gestational carrier to physically carry a pregnancy for you, you're either going to use someone that you know, so a best friend, a sister, a cousin, and in those cases, you need to pay for all the legal fees, the actual transfer of an embryo into that carrier's uterus, and then oftentimes we'll also need to purchase a medical rider for that person so that there are obstetric benefits included for her. And, you know, all in all, I would be ready to spend somewhere between $40,000 to maybe $60,000 in that case. If you're using an agency to find someone for you, and so there are multiple sort of what we call third-party agencies that do a fabulous job of finding women all over the country who will serve as a gestational carrier for someone. In those cases, you're oftentimes paying that person to be your gestational carrier. And so in those cases, I think you should be ready to spend on the upward from $80,000 to $100,000. So it can be extremely expensive. And unfortunately, to date, I don't know of any insurances that help cover that cost. I also don't really know of a ton of financial assistance for that particular need in terms of carrying or finding a gestational carrier, rather. You can certainly look to organizations like Livestrong to help get some stimulation medications. That helps cover, you know, a couple $1,000s. I've had patients who have utilized crowdfunding, which is such a personal choice. We're kind of reaching out to family and friends to help raise funds for something along those lines. I've had other individuals who have taken out medical loans for these types of things, but unfortunately not yet. I'm really waiting for someone with a lot of money who wants to start a foundation or something along those lines to help cover those costs, because it's a frequent question and it's a devastating cost line.
Got it. I thought so. I just didn't know anything out there yet.
Yeah. Hopefully someday.
Okay. Yeah, I hope so. That would be great. Thank you.
As a reminder, that's star one if you would like to ask a question or make a comment. We'll pause for a moment. Caller, please go ahead.
Hello again. I didn't tell you guys my name at first. I'm Latoya. I was the one who asked the first question, and I have a second question. How long after taking the Lupron would the period normally come back?
Yeah, so depending on the dose of Lupron that you were given, there are monthly Lupron injections, and there are also 3-month Lupron injections. So if you were given the monthly Lupron injection, you know, typically your period would come back once that's out of your system. So that only lasts for a month in your system. If you were on the 3-month Lupron, then obviously it's a 3-month time period that Lupron stays in your system. And then typically we see a period come, you know, shortly thereafter the Lupron's out of the system. But again, if you had just received chemotherapy, know that too sometimes can prevent you from getting a period after chemotherapy for some time. And each individual is a little bit different. I typically would recommend seeing a gynecologist or a reproductive endocrinologist for all that ovarian reserve testing once you're at least 6 months, and ideally around 12 months after your last chemotherapy dose.
Oh, okay. Okay, thank you.
Of course.
Next caller, please go ahead.
Hi, sorry, it's me again, Nicole. I had a question. Like, is there a certain time limit after my transplant that people should wait till they actually even maybe try getting pregnant, you know, just to make sure, you know, that everything, I guess there isn't anything to guarantee that the baby would be okay. But is there a certain time limit that somebody should wait before they get pregnant?
Yeah, so in this sort of new frontier of oncofertility, right, we really look to our oncologist to help us make these calls. And so, here we would never allow someone to come see us and do like an embryo transfer without having the blessing of their oncologist, because we want to make sure that everyone on the treatment team is okay with whatever plan's coming next. And kind of, I think it's super important to have that conversation with an oncologist and with your particular oncologist to make sure that, they sort of give their blessing. I would say on average, I typically see sort of the 18 to 24 month mark as being sort of the okay time to attempt pregnancy after all the treatment. And, it's going to be a little bit different for everyone based on your individual care plan and your individual oncologist's opinion. In some cases, they may want to have a survivor follow up with someone called a high-risk obstetrician. So this is an OBGYN who has specialized training in kind of complex medical needs and histories, specifically as it relates to pregnancy. And in some cases, it's just a quick office visit with that person, make sure they don't see any red flags. But in other cases, we have our high-risk OB team follow the entire pregnancy and even through delivery for some of our patients. Again, totally depending on, how you feel after treatment, how everything went during treatment, and kind of what your oncologist feels is going to be best based on a conversation that, you guys have together.
Got it. Thank you.
Of course.
And then as a final reminder, to star 1 to ask a question or make a comment. We'll pause for a moment. Caller, please go ahead.
Hi there. Good afternoon. I have a question in regards to my son who had a stem cell bone marrow transplant in November. The question is, him and his wife went through all the preliminary preparations. He did the sperm freezing. She did something with her eggs. But my question is, after a stem cell transplant, bone marrow transplant, is there any chance that a male can then do it the regular way, like his sperm is okay after it's done?
Yeah. So oftentimes the chemotherapies that we utilize to get someone's body ready for a stem cell transplant put someone in a very high risk category for infertility after treatment, meaning in his particular case, azoospermia, or having no sperm found in the ejaculate. So I'm so glad that someone talked to him about banking before he started that treatment. For male patients, sort of there's this other caveat to being exposed to chemotherapy. Men make sperm with every heartbeat, right? So typically men are making about 1,200 sperm with every heartbeat, which is crazy. But because that sperm is constantly being produced, we know actually that chemotherapy does damage the DNA of sperm. And we see that damage occurring well after a patient's received chemotherapy. Sometimes as long as a year after the last chemotherapy dose, we still see higher rates of DNA damage to that sperm. We think once a patient has been, at least a year out, that damage kind of goes away. The concern with DNA damage is that it may lead to an increased risk of miscarriage, may lead to an increased risk of birth defects, things like that. We don't really have a great way to track DNA damage in sperm because in order for us to actually look at the DNA of a sperm, we have to open it up, and that effectively kills the sperm. So what is typically recommended is that for most men, they wait at least 6 months to a year after their last chemotherapy dose to kind of figure out family building and next steps in terms of that. So in his particular case, still being so new off of a stem cell transplant, I'm sure his oncologists are saying the same thing, maybe to wait a little while longer before he could go in and have a repeat semen analysis done. And that would give him a really good idea of exactly how much of an impact treatment had on fertility. And then likely waiting sort of at least a year after that last chemotherapy dose before attempting pregnancy if he does indeed have sperm in his ejaculate, just to sort of avoid that window of increased rates of DNA damage found within the sperm.
Thank you.
Of course.
And it appears there are no further questions at this time.
Okay, great. Well, thank you so much.
I would like to ask Megan, for the callers that are young and going through this, certainly doing the preservation and everything, these are all important options to provide people. But how did you cope as a young person going through these tough moments? What got you through?
That's a great question. And, when I was diagnosed and when I was sick, I mean, the first thing that, comes to mind is just my will to survive and live and continue on with life. But when you really start thinking about, can I have a future? Will I have a future? Having a family was so important to me. And although I had a great support system of family and friends, I really had no one my age who, was in the same situation or a similar situation as me. So, I probably could have done a little bit of a better job of, reaching out or finding support groups. But my family and friends served as a huge support system during this time. But I think the support I needed grew after my treatment. And that's oftentimes when people think, you're better, you're surviving, you're thriving, but there's so many side effects and post-traumatic stress and other issues that could come along with, surviving a cancer diagnosis. And one of the main things for me that I struggle with now that I have been a survivor and in remission for almost 9 years now is the fertility issue. Although I'm so many years removed from my treatment, it is something that I struggle with every day. And I have found support groups. There's, for me, giving back and providing help to other cancer patients is really how I kind of cope with my own anxieties and worries. And for example, when I was able to testify in front of the Illinois House and Senate to pass this bill, that's so important because I know there are other young adults like myself out there who want an opportunity to have a family later in life. And I just encourage everyone to, find support groups that, you can connect with other survivors or cancer patients that are going through similar situations. As we mentioned, I'm active in Immerman Angels, which is a great, it's a support group that connects patients to patients with similar diagnoses or caretakers with other caretakers. So it's really important to just try to find what support group best fits your needs and how, you can navigate moving on and coping with some of the after effects of treatment.
I really appreciate that because I think that's such an important piece of this, as everyone knows on this call, that it affects your mind, body, and spirit. I also, if someone is feeling inspired to try to make change in their area, to try to get better coverage, is there any recommendations you would have for anyone out there on how you started to make change in your state?
I can speak to my behalf. I think when I was going through treatment, I made some really great connections with my providers, my care team, and most importantly, Kristin Smith, who was a patient navigator at the time. There's relationships made when you're going through treatment, whether it be with other providers or anyone in your care team, even a social worker, who are also passionate about, helping others in the situation and have had experience with connecting people or having connections, whether that be with someone in the legal field or someone in the legal department. So there's definitely connections that can be made and ways that you can find an opportunity to help and give back. And like Kristin recommended, the Alliance for Fertility Preservation is a wonderful resource that also is extremely engaged with legislative issues surrounding fertility for cancer patients or any patient who's at risk for infertility as a result of treatments.
And this is Kristin. I'll kind of add to that. So their website's really fabulous, and Joyce Reinecke, who is a lawyer and also a young adult cancer survivor, really is, I think, one of the smartest women when it comes to fertility preservation and specifically as it relates to legislative actions. And so she single-handedly is going around into all the different states where, she can and starting this whole process. And each state's legislative process looks vastly different. I mean, I had no idea how a bill became a law until we did this process, and it was really challenging and difficult. And so to have someone like Joyce Reineke from the Alliance for Fertility Preservation help guide the way is huge. We need Joyce in that role, but most importantly, too, we need survivors and family members. I mean, Megan's mom and dad were sitting clapping in the back of our Senate and House hearings, and people were excited because no one ever claps at those, and I see why, because they're boring. But to have all that family support and to see all the online support that came through as well, letter writing, things like that, really helped engage our entire state in this process, and I largely attribute that to Megan.
Well, I want to thank you both for the role. I was sharing with the ladies earlier on the fact that having been in the hospital for 20 years myself in oncology, I know it has not always been handled well. And so I'm so thankful for the work that Kristin's doing. And I also thank Megan on behalf of everyone that's going to have a different story based on your work and your efforts. So again, thank you everyone joining us on the call today. Thank you ladies for speaking, but also all the great things you're doing. Just so our callers know, you will be receiving a survey, and if you could fill that out, we would greatly appreciate it. It just helps us to continue to bring you great programming, as well as next month, just a heads up, we're going to have a presentation on how to make the most out of your medical appointments. If you would like further information about survivorship issues or supports available, please feel free to contact us at the link at 1-800-LINK-BMT. We are also looking to expand our peer mentor program for those that are calling to speak to someone who's been through a transplant. If you are interested in helping someone else cope with this journey, please reach out. So thank you to our sponsors, our LINK partners, and I hope everyone has a great day.